Dear colleagues, hello. Good evening to our European friends and good afternoon to our American friends. I am your moderator and chairman of the meeting, Nikos Krompas from Athens, Greece. And we have more than 700 participants in this great meeting that we are going to watch. And I salute you from beautiful Athens. It is with great pleasure and honor that I present to you our speaker and the esteemed members of the panel. Before that, I would like to express my heartfelt thoughts and considerations and sympathy for the Lebanese people and all the problems that the blast has created along the other problems there. But I trust that they are very strong and they will go on, and our hearts and thoughts are with them. And before I present Professor Charles Khoury, I would like to share with you that there will be a webinar on the 9th of September from Quintessence that Professor Khoury and Professor Stefan Kubi will present. It's a webinar to raise funds for Lebanon because this country needs a lot of support and we shouldn't lose it. And we shouldn't lose our this is how we can help our little friends to gather some money and help this country that is in so much need. I would like to share with you that I have known Professor Charles Khoury for many years. When I first visited Professor Khoury's clinic in Olsberg, where he was my instructor. He was my teacher, along with Khoury, in all the wonderful techniques that Professor Fouad has developed. And then I realized how he's an excellent clinician, a passionate teacher, and a great human being. We had many chances in the years that came to be together. We organized excellent courses in Athens, Greece, that were very, very well received from all our colleagues. And it's a privilege for me to call him a friend. Professor Charles Khoury is as complete dentist as a dentist can be. After finishing his studies in St. Joseph University in Beirut, he got his specialty diploma in endodontics in 1996. As if this was not enough, he got his specialty training in prosthodontics in 1999 from St. Joseph University in Beirut, where since 2017, he's a professor of clinical prosthodontics. But he was not satisfied with all this knowledge. In 2002, he got his diploma in implant dentistry from Lyon University in France. And in 2008, he got his master in oral medicine and implantology from the University of Münster. The topic of tonight is the CAROTTA technique. This presentation has huge importance because it's extremely helpful in regenerating bone defects around implants that are done simultaneously. Without any further delay, I present to you Professor Charles Khoury. Charles, you can start your presentation. Thank you very much.
Yes, thank you, Nikos. Thank you for this beautiful and touching introduction. And also, as you said, I will take the opportunity, before I start my presentation, I want, on behalf of me and Dr. Tony Deeb and the whole team behind this webinar and Dental News, to commemorate the souls we lost on the 4th of August due to the blast of Beirut. And this explosion was really catastrophic, and it killed nearly 200 persons. May their soul rest in peace. And it injured more than 6,000 persons to whom we pray for healing. It made homeless for more than 300,000 individuals. We are holding the affected families in our thoughts and prayers. And we would like to express our sincere condolences to each and every person who lost a loved one. I would like to thank Dr. Tony Deeb and the Dental News for hosting me during this webinar. I would like also to thank Dr. Nikos for his introduction, Dr. Buckley for joining us from USA, Dr. Keeve, Philippe Keeve from Germany, Dr. Pierre Keller from France, Strasbourg, and Professor Antoine Khoury from Lebanon. Thank you, dear colleagues. Thank you, dear friends. Our webinar of today is a minimal invasive, and the question is objective of dental implant treatments is achieving optimal aesthetic and functional results. But this depends on hard and soft tissue availability. As much as we have enough soft tissue and hard tissue, and the implant position is right, and the surgical anesthetic has some skills, it's not so difficult to achieve a beautiful case, an optimal beautiful case like this one. And this can be repeatedly and reproducible as much as these conditions are there. But achieving optimal aesthetic and functional result is not enough. We should have long-term stability. And as you can see here, this photo was taken in 2011, and this photo was taken in 2018. And you can see the difference between this natural tooth and this natural, a little bit of recession. And on the implant, here we have small black hole interproximally in 2011, and this black hole was closed. And this long-term stability for this implant is due to several conditions. What makes these long-term stability possible? First, the buccal bone thickness. We should have at least 2 millimeters after implant insertion, or at least during second stage surgery. Meaning, if we're gonna put the implant on the bone level, and still we have a little bit of bone buccally, like 0.5 millimeter or 1 millimeter, we cannot guarantee, even if the totally length of the implant is totally submerged, we cannot give guarantee this will last, because the bone thickness is less than 2 millimeters. And we have a lot of studies talking about that. One in 2000 and one in 2020. Still the same objective. So we have to increase this to give guarantee that this will last. We need a long-term stability. And we should increase it up to 2 millimeters minimum to achieve, after all, at the second stage surgery, a beautiful vital bone with minimum thickness of 2 millimeters to achieve long-term stability. And also, it's not only bone which is important, also the height of the gingival thickness, minimum height of 2 millimeters. Also, we have a lot of study talking about it. For instance, if we have implant, even with 2 millimeter bone thickness, and we don't have fixed gingiva around the neck of it, like this, we cannot guarantee stability over time. We should fix the gingiva surrounding the implant. And here we did a vestibuloplasty of Kazanjian with putting a connective tissue graft under the epithelium. And this epithelium is not keratinized. And it's not important that it should be keratinized. What is important is to be fixed gingiva. And as you can see here, putting a connective tissue under the epithelium and deepening the vestibulum, it gives more stability. And this was after healing of 1 year in 2016. And this was in 2019. Look, the patient came back to change this crown, and we had the chance to take a photo for this beautiful result and beautiful stability through time. Of course, hygiene and disease, diabetes, cancer therapy also can affect long-term stability. We're gonna talk about these now. Sorry, but I don't know why we have these. I don't know if you can see these scratches. I don't know from where they came from. Can you see them, Nikos? Scratches on the screen?
Yes, I can see the scratches and I don't know what they are.
Me too. Maybe those are parasites coming from outside, from audience. I don't know. Tony? Yeah.
Now they're gone. They're gone.
Yeah, they're gone. So now we have 3 conditions. The one with very small buccal bone. I showed you we need to graft it. We can put simultaneously the implant. We have with missing buccal bone. And we have to ask ourselves, can we do a bone grafting simultaneously with implant? And we have the 3rd case scenario, which indicates it's a major bone defect. And the question, is it possible to do implant simultaneously with bone grafting, or we should do bone grafting before and implant later? And what kind of bone grafting? So, first of all, we should study the defect volume and to study if it's inside or outside the bone contour. These scratches are coming back, I don't know why. You can see here, it illustrates how the implant could be outside the bone contour and how the implant could be inside the bone contour. And the yellow schema here is the bone defect. This simultaneously with implant and bone graft doesn't work. This does work. We're gonna explain later. And we have a lot of study talking about this, and even Bach, my friend Bach, also did a beautiful article about it. And you can see the reference here. But how much defect we can allow ourselves to do bone grafting simultaneously with implants? And for me, the most important, if the implant is inside or outside, to be able to answer this question. For instance, the conditions for minimal conditions for bone grafting simultaneously with implants is to have mesial and distal wall, thick wall, because implant should be inside this wall, inside the bone contour. At least lingual or buccal wall should exist, and enough apical bone thickness also, so the bone should surround the implant. And if we have the buccal bone missing, it's okay, as much as we are able to insert the implant inside the bone contour, not like this. Of course, we need also minimum depth of bone to ensure primary stability apically to the implant. These are the conditions for bone grafting simultaneously with implant. The third question, what kind of bone graft? For us, we prefer the autogenous bone. Why? For the simple reason. So autogenous bone is still the gold standard. It's no cost, 0 cost. And it's reproducible. If we follow a protocol and we respect the biology and we respect the recipient site and we understand the biology, all this is reproducible. As you can see here, Only by collecting bone, autogenous bone, from burrs coming from implant bed preparation, it was possible to fill the cavity. It's a self-filling cavity with no membrane, no fixation device, because it's already fixed. By closing and opening at the second stage surgery after only 3 months. Look to the beautiful bone. How it was, how it became. Cost nothing, no membrane, no fixation device, because the situation allowed us to fix the bone into a cavity. Self-containing bone, no biomaterials, no membrane, only autogenous bone, cost $0. And this is second stage after only 3 months. But as I told you before, it's not only to have minimum 2 millimeters. We should have also minimum 2 millimeter high of attached gingiva, and we don't have here. That's why we'd add a free epithelial keratinized from the palate to increase the gingival height, and that's how it was possible to give long-term stability, bone and fixed gingiva, autogenous bone and fixed gingiva. And this was in 2019, after 11 years. But what about this condition? After 4 months post-extraction, we still have a cavity. We didn't have any remodeling of the bone. So here it's not possible. It's not a self-containing cavity. The lingual bone is missing, the buccal bone is missing. If I'm gonna put a material inside without fixation device, it's unpredictable to be fixed, because this requirement for successful bone grafting is stability and fixation. That's why in this situation, different than the other situation, we need a fixation device. We should ensure maximum blood supply from surrounding bone and soft tissue, because here, for example, if we do a flap, we can see small vessels coming from the bone. Where are these vessels are going? They are going through the soft tissue. It means there is exchange between soft tissue and bone, and we call it angiogenesis. And we're gonna put a membrane here. We're gonna interfere. We're gonna disturb the soft tissue and the blood-bone exchange. It will be an inhibition of angiogenesis, and we don't like this. We want to have a beautiful, successful rate, always reproducible. That's why we don't like membranes. Space maintainer. We should also fight against lingual force, buccal force, soft tissue tension after healing. So we need to tent the periosteum during the bone remodeling and the soft tissue. Recognized by periosteum. We want our material to be recognized by we don't like to have fiber integration. Sometimes if I'm going to use a resorbable membrane, if it resorbs too soon, some of this material can be fiber integrated. And if I'm going to use a membrane non-resorbable, some of these biomaterials can go through around the membrane and go to the soft tissue, and also can be fiber integrated. But only autogenous bone, if it's really fixed into the socket, it's not gonna be fiber integrated. Totally remodeled within 3 months, at least 60% of it. This is what I want. When I'm gonna do a second stage surgery, I want more than 60% of it totally remodeled. Minimizing the cost as much as possible. That's why with a tray finder drill into the bed preparation of the implant site, we're gonna make a carrot with a tray finder drill. Remove it, and this carrot is coming from the spongy bone, the cancellous bone, not touching as much as possible from the cortical. And also by deepening also the drilling, and also by removing from little bit bone during bed preparation, I collect bone chips. So we're gonna put 2 tenting screws. Those are stainless steel screws away from the implant at least 2 millimeters, and fix the 2 carottas on the lingual part. squeeze them between the implant and the screws. Buccal is the same. We're gonna put 1 or 2 screws and fix another CAROTTA. And what left as space is gonna be filled by what we collect from the drill, implant bed preparation drill, bone chips. We know membrane, no biomaterials, clothing the wound. This is directly after the surgery, 1 week later. And we can see here the tenting effect of the screws that also my friend Bach described it in several articles. Tenting screw during bone augmentation. And also Fuad. And we can see those are screws made in a gentle way, not to perforate, but sometimes it perforates, but most of the time it doesn't. I'm gonna show you several cases like these. These screws will minimize the tongue effect, will minimize the cheek effect, will minimize the tension effect of the gum to resolve the autogenous bone during bone remodeling. And look here, the beautiful remodeling of bone. It's a bloody bone. After 3 months, blood is coming out from it. If we're gonna compare it how it was white before, now it's become vital. And we can see on the inner side of the screw, there is a close contact with bone, meaning the CAROTTA didn't resorb. It was remodeled. This is what I call a tenting effect by the screw. Maximum blood supply, no angiogenesis inhibition, no membrane, tenting gently the periosteum and soft tissue, recognized by periosteum, no fibrointegration, totally remodeled 60% bloody bone after 3 months, minimize the cost as much as possible, no biomaterials, no membrane, no second wound morbidity, instantly minimal invasive from the same implant bed preparation. And you can see here, after the day of insertion, you can see the bone was not totally remodeled after 3 months, 4 months. And this is after 3 years. You can see the difference in densification. Look to this bone and look to this bone. Densification, more densification. Reproducible, another case, totally similar. Reproducible, the same result. CAROTTA didn't resolve. Close contact after 3 months with the inner side of the screw. No resorption. Easy, safe, reproducible. And this is the result. Also, soft tissue management, always important. Deepening the vestibulum, creating more attached gingiva. This will give a long-term stability. But schematically, I'm gonna show you how this will gonna work. Here, for instance, buccally, we have more than 6 millimeters of defect. But you just told us we shouldn't exceed more than 4 to 5 millimeters. As much as I told you, what's most important to be inside the bone contour. As much as we can insert the implant inside the bone contour, how much the bone defect high is not important. We can do it as much as inside the contour. Inside the contour is the most important. So with a tray finer drill, inside the bone contour, and we have 2 options. Either the CAROTTA will stay inside or it comes out with a tray fine. If it's inside, we have a device, we can remove it, as you can see here. This is a device to remove the CAROTTA. And if it comes with the tray fine, it's also, there is another device can push the CAROTTA outside to use it. Inserting the implant inside the bony contour. It's the most important thing. Put the CAROTTA buccally on the top, on the edge, on the neck of the implant. Make a hole for the screw. Those are stainless steel 1 millimeter screw. And this is schematically and clinically how it's done. And what we collect from apically and with the drills of the implant bed preparation, we can put around it no membrane, and of course, we're gonna relieve a little bit the periosteum, cut the periosteum apically to have more elasticity, tense-free suturing. And look one more time, tenting effect of the screws. And after 3 months, we can do second stage surgery, how it was before. Only 3 months later, simultaneously with the implant insertion. The day, of course, you can see the day of insertion, and this is after 1 month. I couldn't see the patient for a call, for a checkup. But as much as we have enough soft tissue, fixed soft tissue, and enough thickness of bone. Now I'm gonna show you a movie about the technique. This is a bone defect. It was done simultaneously. With the sinus floor elevation. I'm gonna not show you the sinus floor elevation. And this is how we're gonna push the carotta outside the trifine. And we're gonna continue drilling, collecting more bone chips slowly, without irrigation. So putting the implant on the level mesial and distal, on the bone defect, buccally and palatally, we're gonna do 2 carots. We're gonna make a hole for the screws. We're gonna squeeze the carotta between the implant neck with the screw buccally and palatally. And filling the rest with autogenous bone. The screws are made by Mesinger, and these screws has a 1 millimeter diameter and has another screw 1.2 for backup. If these screws become loose, we can have a backup 1.2 millimeter after closing. And this is, you can see it. You can see the bone defect, the shadow of the bone defect, how it was, and after filling it, how it became. And 3 months later, look, no resorption inside the screw. The same contact as we left stayed the same, and we have at least 2 millimeter on both sides. And what's this? What gives a long-term stability? It's a bloody bone. It was white. It became blood after 3 months. Autogenous bone, fixed bone, no inhibition of angiogenesis, quick respond in 3 months, quick result, fixed gingiva, and stability. Another case, a little bit more complicated, with a little bit more defect on the palatal side, on the buccal side, for 2 implants. Here you can see the palatal side, a little bit more defect than here. 2 carottas inside the bony contour, quickly collecting the bone with trifine drill kit, low speed drilling on the apical to collect more bone chips, putting the implant. You can see here we put the implant on the level of the adjacent bone. Because some of you will say, why don't you push it more? Because we cannot guarantee aesthetically later if it's gonna have a good papilla and a good buccal. Here it comes. So very important to put on the same adjacent tooth level the implant position inside the bone contour. 2 carottas, one goes buccally, fixed, but here I made a comparison method. I tried to do something different. I fixed this buccal carotta in the middle. I didn't use the screw buccally. I didn't squeeze the carotta with the implant. I perforated through the carotta. And palatally, I put a screw buccally, more palatally. I squeeze here, I squeezed the carotta with the screw. Here, I put the screw through the carotta, just to make a study, to show, to see if there is a real effect of tenting screw. Also with the Meisinger kit, look, and we filled the gaps with autogenous bone. One screw in the middle of the carotta, through the carotta. Here, one screw back outside the carotta, squeezing it. And this is the result after 3 months. Look here, to this lateral, natural lateral crown, and this here, the papilla, how it gains, how the soft tissue looks nice, how large is the crest later on. And this is how it was before, and this is how it became later. Look here, both implant, autogenous bone, 3 months, it all totally filled up to the level of the cover screw. But look at the difference between here, buccally. We have a little bit of resorption of the carotta, like 1 millimeter or 0.5 millimeter. Here, the screw didn't play an effect of tenting the soft tissue. But here on the palatal side, the same case, the whole thickness of the carotta stayed where we had an effect, tenting effect of the screw. This is why we always recommend to put the screw buccally, not through the carotta. And second stage surgery, this case was done in April 2019, before COVID. And in July 2019, before COVID, we did the second stage surgery. And the patient disappeared. She was supposed to go to her doctor and to make the crowns. And she disappeared due to COVID and so many complications in Lebanon, we couldn't see her. We called her like 1 month ago. It was on the 4th of August, she came, the day of the blast. So the day of the blast, it was in the morning. The blast was in the afternoon. So she came, and we saw a fistula. We saw something we didn't understand. We asked her what happened. She said, due to COVID, I couldn't come really. And I have to put some correga inside to fix the bridge over the implant. And he said, what have you done? And look what was inside. It was fistula, pus coming out. So we cleaned everything and looked to the X-ray. The bone is still there after 1 year. We cleaned everything. We put back the crown. And this was 2 weeks after. It's a vital bone. It's fighting to survive. It's not biomaterial. It's a vital remodeling bone. And when I finish my case with this final case, 8 weeks after the post-extraction, we have a nice soft tissue, but bone is still missing. And as we can see here, the bone level on the mesial distal is higher than the interproximal buccolingual. We put the implant on the mesial distal bone level, and we have missing bone here on the buccal side. Even if the implant was totally covered, we decide to graft with a trephine drill with kit. We collect several bone carottas with command, also bone chips with drills, and we fixed here to increase the bone thickness, here to increase the bone height buccally, here also to increase the bone height lingually. Because the implant is inside the contour, it's possible to do it only with autogenous bone. 100% autogenous bone, filling the gaps, closing directly after the surgery. 3 months later, you can see the remodeling, beautiful remodeling. The X-ray show it. All one more time, tenting screw effect. Here, the beautiful bone, bloody bone. It's a bloody bone. Blood is coming out After 3 months, look, it was white. It became red with 1 millimeter to 3 millimeter thickness on this side. Lingual. We have all, even bone growing over the implants. Autogenous, pure autogenous. After removing the screws, of course, soft tissue management is very important. I'm not gonna go through this. Fixed gingiva. 4 weeks later, impression taking, and the final reconstruction is there. I finished my presentation. And now I'm gonna give the speech for my friend Nikos. I'm gonna talk a little bit about him.
Thank you, Charles.
Nikos is graduated in '83 from Aristotelian University of Salonika Dental School. He started his training in '91 in Brandmark Clinic at the University of Gothenburg, Sweden. He practiced in Athens, Greece, the past 35 years with his lovely wife, Nota Stefanopoulou, which I have the honor to know her very well. The focus of his practice is concentrated in implant dentistry and fixed prosthodontics. Since 2013, and in collaboration with the Professor P.I. Brandmark, he established what we call the Brandmark Associated Osseointegration Center in Greece, ABOCG, as a certified center of excellency in osseointegration. The goal of BOCG is to offer the patient and fellow dentists the highest quality of care and education. And since Dr. Krompas is also involved for more than 18 years in teaching dentists advanced concept in occlusion, aesthetic and implantology, and has established the Krompas Seminar Institute. Dr. Krompas, the word is yours. Thank you for being with
Dear
us.
Charlie, thank you very much, my dear friend, for a very informative and to the point presentation that you also taught me 6, 7 years ago and that I do every day in my practice. And this is a subject, I will take only 2 or 3 minutes, you know, to position myself. This is a subject that is very controversial, like bone augmentation, because everybody's doing bone augmentation with different ways. My studies for 35 years and clinical experience in implant dentistry, in hard and soft tissue augmentation, has made it very clear that our highest priority should be the safety of our patients and the well-being of our patients. And second, the long-term predictability of our treatments. And finally, and most important, our respect for biology and physiology. And all these considerations have to be realized with proven, but not very complex, because we can do very complex and prove that we are very great dentists and surgeons, and minimally invasive techniques like you showed. Also, the logistics and financial costs must be taken seriously in other considerations so that a lot of patients can benefit from the fantastic programs that dentistry has achieved, not the few very rich patients that can afford it. So on the one hand, in the bone augmentation range, we have the big surgeries that we did 25 years ago. We took bone from the hip, from Calvaria, and we were good surgeons, but the patients hated us. We had intraoral and extraoral donorocytes. On the other hand, on the other edge of the range, we have the people that teach only biomaterials and membranes, but also with nowadays simultaneous use of bioactive modifiers like PRF and PMPs, like my mentor, Dr. Nikos. So the young clinician embarking in this journey of complete and predictable implantology and tissue augmentation is very highly perplexed. He doesn't know what to do. And this is because most speakers and teachers are paid influencers of companies that sell the biomaterials. So they're biased. And always you have to ask all the, the disclaimer. And if you use autogenous bone, you don't have any disclaimer because it's made from nature. So for me as a seasoned veteran, the CAROTTA technique using the golden standard of bone graft materials, autogenous bone, like Fouad also says, and I think he's watching us now, with a minimal invasive surgery and morbidity that I can use in the majority of the cases that we do in our offices are cases like you showed. It's not the big full arches, are 1, 2, or 3 implants. It's the first choice and preference. And thank you again, Charles. Congratulations, my friend. But now I would like to very briefly present the members of our scientific panel, all accomplished and excellent surgeons, much better than me, with a vast experience in bone augmentation, who will share with us their opinions on the presented technique and discuss all pertinent questions. And I will start with the moderator that will take all our questions, Dr. Philip Keeve, who finished, he's very young, he finished in 2008, but he's an excellent surgeon. He's a periodontist. He was also, he has a master in oral surgery from University of Münster. And since 2018, he's in private practice in Hameln, Germany. Our second panelist is Professor Bach Le. Le or Lee? Lee. Bach Lee. Bach Lee. Okay. Thank you very much. Professor Bach Lee completed his specialty training in oral maxillofacial surgery at Oregon Health Science University. And currently, he's a clinical associate professor at the Herman Ostrow School of Dentistry at the University of Southern California. He has authored over 14 chapters in textbooks on bone regeneration, dental implants, and he has published extensively. And he's a member of everything that you can imagine, of any association. Dr. Pierre Keller, he's with us. He's in private practice, he's oral surgery. He's also a master of oral medicine implantology, University of Münster. And he's also a maître en sciences biologiques et médicales from the University of Strasbourg, France. And this is all. And now, Philip, you can take the questions and we can go on. And no, excuse me. The most important, Professor Antoine, one moment. Antoine Khoury. One moment, because Professor Antoine Khoury, a friend, and he's a former head of the Department of Oral Surgery in St. Joseph University in Lebanon, and he's the coordinator of the implantology program and director of the postgraduate diploma in oral surgery. And I had the privilege some years ago to be taught by him in Beirut, Lebanon. So, Philip, you can take the microphone.
Okay, dear Charles, thank you, Mr. Krompas, for this nice invitation, and for all participants who just watched our excellent lecture. And I also just described in the chat that you are very welcome to post your questions into the chat, and we will just have question and answer session right here after. And first of all, I want to invite all the panelists to give a short statement about that CAROTTA technique, which is described in this beautiful lecture. So probably I would invite to have Pierre Keller for his opinion about what he is using the CAROTTA technique in common life, in his own practice, and what he thinks about the advantages of this technique, or probably also about the disadvantages who he made in the last years with this technique. So Pierre, if you can share your opinion about the technique and what you can share with the participants.
Sure. Hi, Philip. Thanks for the question. So I really enjoy the lecture of Charles, for sure. was really good. I really appreciate the schematic. He explains the controls and everything. I think it was really interesting. And for sure, I have some good experience with the CAROTTA technique, as you and as everybody, which just try it, because it's a very simple way to collect some bone, and I think it's the best way in normal case to augment this bone around the implant, as Charles showed us. And for the daily work, it's the best. It's a very useful technique. What I have some experience is sometimes I have some patient disclaim about the screw. So I think it's a very easy thing, but you have to explain the patient. He can have the feeling of the screw with the tongue or with the lip during the healing time. Maybe about 2 months later, 2 months after the surgery, sometimes the patient just feel with his finger, and if you just explain the patient, he will sometimes is this effect of the screw of this, like a tense, like explained Charles. It could be a good things to do. What I would like to ask maybe Charles is if he sometimes like to combine a connective tissue graft with a CAROTTA. If he try and if he have a good result, or if he didn't do that. Charles, maybe you can answer.
Yeah, of course, but even so, because these stenting screws most of the time are outside the bone contour. And if the soft tissue already was thick enough, we don't need to put a supplementary to add a soft tissue. Of course, if the soft tissue at the beginning was very thin, we should put some more soft tissue to make sure there won't be any dehiscence or wound opening and something like this, or necrosis. Of course, soft tissue is very important. But even so, because of these screws are most of the time outside the bony contour, only the screws, I'm not talking about the CAROTTA. That's why they minimize all the tension that can affect the CAROTTA that I showed you before the case before the end, how it prohibits the bone resorption. So even if we're gonna add some soft tissue on it, maybe it will stay away, like the case I showed to you. Sometimes it stays away if the gingiva is really thick and really hard, if it's the patient has a thick phenotype. But most of the case, we can see them through the gum. But it doesn't matter, it's something temporarily. As you said, we can explain for the patients only for 3 months, and we're gonna remove them. They are not gonna stay forever.
Yes, thank you, Charles. Thank you for this really clear answer. I completely agree with you. It's really rare, but sometimes it happens. So we have a small dehiscence of the head of the screw. What do you advise? Do you advise to take out the screw as soon as possible? If it's happened, it's really rare, but it's happened. Or do you advise to keep it clean and keep the screw in place? What would you advise for colleagues?
Really, it's not very important about that, because usually if everything was correctly done, if the thickness of the gum was sufficient during the surgery and we close it in a very stress-free way, the dehiscence won't appear before 1 month. It's impossible, won't appear. And after 1 month already, the bone is integrated, it's solid, it's rigid. So whether we can keep it or we can remove it, if it appears outside the gum, doesn't matter, because bone is already there. There is no, it's not such exposure. It's less than 1 millimeter around the neck of this mini screw. It's totally hermetic. We don't need a suture after removing this micro screw, and the bone is still there. It's autogenous. It's already starting being vital. So We only open at 3 months for the osseointegration, more than the remodeling of the bone. Because if we're gonna open after 2 months or 1 month, so we have a big chance to see the bone is there and fixed, is integrated. And we can recover it during the second stage, but we don't dare to do it due to maybe the implant wasn't enough osseointegrated. We wait 3 months to have simultaneous result of maximum bone remodeling, optimal bone remodeling, if you want to say, and at the same time, a good stability and good osseointegration of the implant.
Okay, thanks for that really clear and interesting answer, because as Pierre just mentioned, there are rare cases where we see screws in after CAROTTA technique, but I have never seen a screw inflamed in the tissue. So this was very clearly from you, Charles, that we can just are relaxed with the situation if that happens. I would just want to ask Bach for his opinion, because we read a lot from your scientific board and your scientific studies about GBR as well, and probably you have a comparison for us between the techniques of CAROTTA and the guided bone regeneration, and what you think about those advantages or disadvantages of both techniques.
Great. Good day. It's morning here in Los Angeles, and so it's evening over there. First of all, I want to extend, you know, my heartfelt thoughts to all the people of Lebanon through all the recent tragedy. As you know, Charles, I was there about 1.5 years ago, and Professor Charles Khoury hosted me and took me and really was a generous host, and I really want to extend my gratitude. And I you know, want to say that the people of Lebanon I found to be very warm, resilient, and very strong, and I'm very sure that everybody will recover from this. So the next, on to the next topic, I want to congratulate Charles. This is a great presentation. I, you know, was amazed at the presentation with some of the thoughts that you showed with the technique. It's very innovative, and it gave me some ideas. We in bone augmentation has been done for, you know, over, you know, a few hundred years now. And yet in 2020, we still have many different ways to do bone augmentation. So, you know, that is a testament to the fact that we, as a specialty in implant dentistry, we seem to have not great consensus. Because if you ask one person, they may have this idea, another person may have this idea. And if you practice long enough, the common saying we always hear is that if you practice long enough, you see everything go into full circle. So, and the reason is because there's always a new technique that comes out, and then we find that, oh, the other technique didn't work that good, so we learn the new technique. So eventually it comes full circle. And I would say that right now, the full circle is autogenous bone. We started with autogenous bone many years ago. In my training, this is all we did. And then we gravitated towards all the different techniques. And now we're coming back to autogenous bone. I do believe autogenous bone, as you presented very clearly, is the gold standard. So my first choice always is to go to the gold standard, which is autogenous bone. And one of the major advantages that you presented is that it is, you know, it is free in the sense that there is no extra cost for biomaterial. And the second advantage is that it is rapidly integrated. So I think that there's no question. And then lastly is osteogenic. So with that, I think that has major advantages. I had some thoughts when you were presenting it, and some of the panelists had discussed about the screw heads getting exposed, which is very common. I've been using the tenting screw technique for about 2 decades, and that's a very common problem that I see. And one of the things that I actually was thinking when you presented that is that one of the strategies that I use to prevent that from happening is to actually use biomaterial. So we use the autogenous bone almost like a sandwich over the tenting screw, and then layer the material to buffer the resorption. Because we know that every graft material that we have available to us, including autogenous bone, has resorption. And in fact, a very recent systematic review shows us that within 6 months, even with block autogenous bone, they recorded about 30% resorption. So because of that, we don't throw the baby out with the bathwater. We can still use the technique, but we have to prepare for the resorption. To prevent that, sometimes I would layer the autogenous, biomaterial over the autogenous bone, then put a membrane. And so there was a lot of questions about, do we do a connective tissue graft with the technique, which to thicken the tissue. What I've done is to put a membrane over the biomaterial. And what I have found is that it decreases the resorption and also decreases the screw head exposure that I've seen. It's not a big deal to get the screw exposure. But what I have found to be helpful is that it protects the autogenous bone. So you gave me an idea when I was watching your presentation. I was thinking, that is a great idea to harvest this little carrot and then place it strategically, as you did, at the crest. And then possibly maybe layer, in my hands, to layer it with some type of biomaterial to prevent or decrease resorption. When I graft, I like to over bulk the material. So you talked a lot about that bony housing. I actually like to graft outside the bony housing. So the reason is because of the anticipated resorption. So I will graft outside the housing. I expect some resorption into it. And then, and I have also found that with the combination of that, it actually improves the soft tissue thickness. So if you go back and you find that the tissue, as you've shown in some of these cases, the tissue actually quality improves significantly. So that's one thought that I had is maybe, to combine it. The second thought that I also had is, do you find that the quality of the bone affects the long-term healing? For example, sometimes we go in and we take a core, as you've shown, but the quality of the core is poor. For example, maybe you're placing it in the posterior maxilla, you take the core, and the bone is medullary, and maybe you don't get quite the nice hard core that you can fixate. What do you do in that situation? You go to another site, and then the second question is, if you place this, when you harvest this core material, is there do you prefer a consistency in this core to decrease the amount of resorption, or whether it affects it?
Yeah, it's very common what you just said about the softness of the core, but it doesn't matter. Because what's really, if you follow the concept of the biologic concept of thinking of bone grafting that Fouad taught us, it's not the cortical bone which is important. It's the cancellous bone. More it's cancellous, more it's easily remodeled and quickly remodeled. More it's cortical, more it's slowly remodeled. That's why Fouad, when he's used to remove bone from the retromolar area, he doesn't graft it as a block because it's too much cortical. And the CAROTTA, what we are using, is almost 90%, it's not 100% cancellous bone, not cortical. It's inside the bicortical layer. Because we should have enough thickness of bone to have it. And if we have the resorption buccally, we're gonna go more little bit palatally, but 2 millimeters away from the palatal side, meaning it's still inside the canthus. And sometimes if it's not hard enough and it's soft, as much it still sticks together in one core, we can use it. But sometimes it's not possible. It's too fluffy, too loose, or there is rare bone about it. If it's only a single implant, we may go, if it's an upper arch, we may go into the palate, the same region. If the sinus is a little bit far away, and or it's anterior region. On the palatal side, we can always harvest a little bit bone chip from the carota, and it's hard enough. Okay, we can have a little bit compromise, but it's a little bit cortical. And I told you before, those are exceptions, but still it's gonna work. And we're not gonna count on the carota to be totally remodeled. If we saw on the schematic way, the carota touch only in one point the implant. It doesn't touch on the whole defect of the implant, the carota. It's only one point because it's straight and the implant is round. It's gonna touch like this. So here, we don't care if there is happening osseointegration or not. What's important, it's acting as a shield, as a membrane, as a natural membrane barrier. And the bone chips that we are insisting about it in every time, squeeze them between the gaps. These will provide osseointegration after 3 months and not the carota. But the carota is a shield, protecting shield. And as I told you, every time if we're gonna do a morphometric study on these bone after 3 months, we're gonna see only 60% of it remodeled. So the rest of it will remodel it later. But the one is in touch with the implant is directly totally remodeled because those are very tiny bone chips. This will ensure osseointegration. I don't know if I answered the question properly.
Yes, yes, yes. Have you noticed if the difference between using the carota and let's say if you were not able to harvest a nice stable carota, if you had just packed the chips around the implant, do you notice a difference in the results?
No, but I have to fix them. I showed you the first case, it was a cavity. It was a cavity, self-embedding cavity. So just to put the bone chip without carota, without anything, without screw, without membrane, it was already fixed. And we have the mesial wall and the distal wall going forward up to the buccal wall. This fixed, those were enabled to fix the soft tissue dehiscency, not to press, to make too much pressure or muscle pressure on the bone chips. And it worked, as I showed you. And I have a background as 11 years about it, stability. So it depends if your bone graft is stable. The major important thing is stabilize the bone graft. This is the more important. And the second, which equal to that, is to be inside the bone contour. Inside the bone contour, because this is the source of osteo coming to the bed where I graft the bone. I should have enough surface of healthy bone to come toward the cavity. If the bone was in a retrieve position, it's really hard to have the osteoblasts jumping away to go inside. And we will have the implant which prohibits this. If the bone is outside the implant, then the osteoblast can come and invade the site and we have a quick remodeling.
Okay. Thank you very much for your both experiences. I'm very interested in those topics. So thank you very much. So Antoine, I just want to ask you, do you have some tips for participants who just want to start with the CAROTTA technique? Which parts or techniques or probably parts of the technique should be emphasized, or do you have some tips for the beginners who want to start with CAROTTA technique?
Antoine, I think you are on mute.
Oh yeah,
you should remove the mute. Make unmute the speaker
at the bottom left
on the
side.
speaker icon. Yeah.
Right.
Excellent. Yes, thank you.
Thanks, Philip, for your question. To be starting, I have to congratulate Charles for this remarkable presentation about the core technique. Thanks for Dental News, Tony Deep and the team for this live webinar. And concerning the question, it's a new technique. Our faculty, we treated all patients with the micro-saw technique. You know the micro-saw technique of Fuad, but you know this new technique is since 2018. That's meaning the first publication of Fuad with D'Olivier in the International Journal of Perio was in 2018. And this technique is the new one. We need more experience with that to be treated with students at the faculty. I answer your question, Philippe, or no?
Yeah, thank you very much.
Thank you, Dolly.
So a short reminder, if there are any questions from participants all over the Zoom, you are very welcome to post your questions into the chat and we will discuss it with Charles and all the other panel experts. So at the end, our panel expert, Mr. Krompas, I just want to ask you, Nikos, do you think in a CAROTTA technique, you have to use a trephine burr, which is for beginners probably difficult because you have to just have at the first try, you have to get an excellent implant bed. You don't have a procedure to correct something. You are, for beginners, it can be a hard challenge. So is there, your opinion, is there any device or a trick to just be aware of cases which can be difficulter or using the CAROTTA technique even in difficult cases, right, for beginners?
Absolutely, this is a great question. And you know, you have one chance with the osteotomy because if you have only the CAROTTA, the trephine, the outside diameter is 3.5, the smallest one. Inside is 2 millimeters, the smallest CAROTTA. Correct me if I'm wrong, Charles. So you see, it's another big drill for the osteotomy. So I advise very, 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 very strongly all the inexperienced, or when you start with this technique, to have a surgical guide. So you go with a trephine, because you may destroy the osteotomy. Because as a Brennemark trained clinician, I always do screw retained. You know, I saw Charles is doing a lot of cemented. I don't like cemented at all. I do only screw retained. So the osteotomy should be perfect in the middle of the occlusal surface. So it's very difficult if you're not experienced to do the right osteotomy, as you said. For me, this is the biggest problem. For the technique, all the other details are great, but you have one chance to do it right. While if you use the incremental drills, you can start with 1.2, go to 1.5, and then you can correct the osteotomy as you go along. And you can do your direction indicators, but with that, you cannot. So you're absolutely, this is, you're right, Philip. And I would like also Charles to position himself, to elaborate on that. How, because I haven't seen, because this technique, Antoine said, is new. I have been taught this technique 5 or 6 years ago, but the evidence is new, like the publications 2018. We are doing it 5, 6 years now. But what I saw from Charles is that he never has used, or Fouad, they never use a surgical guide. At least from what I see from the slides. So I always use a surgical guide because, you know, my other hat, my other personality is a prosthodontist. So I want everything to be perfect, because if it's not perfect, I will pay the price of my surgery. So Charles, please, can you elaborate on that? How you do the perfect osteotomy from the beginning?
Of course, Nikos. Of course, we use a surgical guide, especially in the anterior region, but because it's not our major topic during our presentation and during courses to talk about it. And in the anterior region, we always use surgical guides.
No, for the carota, we said, no, not for
yes,
the, not for the simple implant, for the carota.
No.
Carota,
absolutely, we always try to use a surgical guide, always, especially in the anterior region. Maybe in the posterior region, if we have already some teeth on the mesial part of it where we're gonna put the implant, we're not gonna use it. We have experience enough in that.
Absolutely.
But in the anterior, we never play with aesthetic. We never play, As I showed you, it doesn't come like this beautiful aesthetic without surgical guide. It's impossible. So, but we're not showing them because it's not our topic. Now with the new Trefine kit of Mazinger, that I just showed it to you during the, I didn't explain about it. There is a guided pin before the use of the carota. Before using, it's a new surgical kit for the Trefine carota preparation. It's a brand new. It has like 2 years old when it started, and they start publishing it and into market. Start 1 year ago, I think maybe 9 months, not before. And Fouad developed it due to the lack of something that what you just mentioned.
Yes.
And we start with a small pin, with a very sharp pointed pin, with a surrounding teeth, small teeth. I cannot explain it to you. I don't have the.
Yeah, I know. I have the kit for 1 year. I have experience with the kit.
That's why Nikos tell you it's a new technique. Because when I talk with Fouad, he tell me he treated 186 patients for 5 years follow-up, radiological, and exam every year, CBCT and others. We start with a Trefine with internal diameter 2.5 millimeters and external 3.5. After, like Charles tell you, the new micro screws and the other techniques. That's why when you have to follow Fouad, you have to run after Fouad. That's why I tell you it's a new technique. Okay. We wait always to be on the safe side, and the success is better than the failures.
Okay.
Thank you very much. We have one question from our participants, probably for Charles. He has asked, small defects are for the carota techniques, big defects are for the block harvesting from the retromolar area. Would you agree, or just please answer the question?
It's not as simple as that. We can simplify the thing. The most important things, are you able to put the implant inside the bony contour or not? This is the major question. If we are able to position the implant inside the bony contour mesially, distally, buccally, lingually, apically. We have a big base. It's possible to harvest some carottas from the implant bite site or a little bit around it, and to put the implant inside the bony contour and graft it simultaneously with carottas. Sometimes it can go up to 7, 8 millimeters buccally, but on a narrow scale, very long in height, narrow in width. So it's more than 4, 6 millimeters. Sometimes it goes a little bit wider. As much as we are inside the bony contour, it doesn't matter. But if the crest is really far away and it's very thin from crestal to apical, no way to stabilize the implant, no way to harvest the carotta. It's a bone very thin from top to the apex. And even so, if the bone compared to the mesial part and to the distal part is really far away and very thin, it's impossible to do simultaneously with bone graft. So we should do bone graft before, then later implant. Sometimes, so many times, we have like 6 to 7 implants to put, or to 6 implants to put. And on one side, we have 0 bone. Like, we should do bone graft. From the carottas, we collect from the other side, and there were enough bone. We didn't need to use the carottas to bone graft it. Where I couldn't put the implant simultaneously with bone graft, with these carottas, 5 to 6 carottas, I can put with the screws, with the mini screws, to bone graft 3-dimensionally the site, but without implant. So sometimes it's not always we should go to the retromolar region. Only we have to think to work wisely. If I have to put 6 to 8 implants, and I was able to put 6 implants, and the 2 last implant, it was the totally destroyed bone. With the carottas I collect from the 6 implant, I can make 3-dimension bone grafting enough. After 3 months, I can put the implant later, instead of going to the retromolar region and harvest the bone. Of course, when I don't have this situation, I have to go to the retromolar region.
Okay.
Thank you very much, Charles. Thank you very much for this excellent lecture, and thank you very much for this very interesting panel discussion we had here. We have no more questions in the chat, so that's the reason why I want to give the last words to Nikos, closing the session and finding the last words. Thanks.
Okay. Okay, it's already 1 hour and 20 minutes. Although I know you were very careful not to go far away. I know you have so many cases that I have seen, excellent cases that you didn't show us tonight. And so you open our appetite for your next webinar. And thank you very much. Congratulations. Thank you to everyone, to Antoine, Philip, Pierre, and Bach. And I wish after the coronavirus that we meet all in person. And I wish all the Lebanese people in Beirut to find again their life. And maybe in 1 or 2 years, this is all a bad dream, and we are going to be together and have some wine, maybe in Athens, or in Beirut, or in Los Angeles. And I wish you all a very nice night and a very good September that is coming. So we should all stay healthy and safe. And everything bad will go away because life is good. So,
and we hope to see you all soon in Lebanon.
Okay,
You are
okay.
welcome always.
Bye-bye.
Cheers, everybody.
Cheers,
And
cheers.
stay safe. And thank you for sharing your experience. Thank you, Bach. Thank you, Philip.
Bye-bye.
Thank you, Tony. Thank you, Nikos. Thank you, Pierre. Merci
Ahlan.
beaucoup.
Thank you, Charles.
Bye-bye.
Okay.
Merci.
Bye.
Merci tout le monde. Bravo.
Bye-bye. Merci,
Au
Philippe.
revoir. Au revoir, Pierre.
Allez.
Au revoir.
Bravo, Charlot. Bravo.
Bravo.
Good.